Well, thank you. And thank you all for being here. It's really a great pleasure to be able to bring you back some data from the SCN2A clinical trials readiness study and update and on some emerging findings with the collaboration with Dr. Al George's lab at Northwestern. There's been a paradigm shift with precision medicine from seizure suppression or symptom suppression to actual disease treatment. And the question is, what is SCN2A related disorder, if not seizures? I think you all know that seizures are important, but they're not the only, or even sometimes most important part of the disease. And sometimes, for some people, they're not even part of the disease. So what should the targeted outcome be for precision medicine therapy for SCN2A? That's why we've been doing the SCN2A CTRS. And the purpose has been to develop a robust primary SCN2A phenotypes beyond the seizures, identify frequency of neurological and non-neurological morbidities, trial several clinical outcome assessments in people with SCN2A RD with the question of, can we measure better in the face of moderate to profound impairment? Just to make this point, I think several of you know my analogy of if you have a baby mouse and you're watching your baby mouse grow and you want to monitor how it grows, you put him on your bathroom scale and he weighs 0. And a month later, you can see that he's grown, but you put him back on your bathroom scale and he still weighs 0. And that's how so many of the clinical outcome assessments work in children with a disease as severe as SCN2 related disorders. We need the right measures, and that's what we've been trying to do. Fascinating as that is, that's not what I'm going to talk about today, but I just want you to know it is front and center in the work we're doing. We have had the absolute pleasure and fantastic opportunity to partner with Al George's group, and I'm going to be giving you a little bit of a taste of what we're finding, and I think it's really important given all of the discussion that's gone on about variants, their effects, and phenotype. The SCN2A CTRS began a few years ago during the pandemic. I think most of you are familiar with it. How many of you have participated in the study? Yay, thank you all. But overall, across the world, we have 81 families. We've talked about the primary phenotype already in SCN2A-RD, and you've heard about the traditional breakdown of early onset, less than 3-month seizures, later onset, 3 months and older, and then autism or intellectual disability without seizures. We've taken a somewhat more nuanced approach and specifically broken out neonatal onset epilepsy. Neonatal epilepsy has only recently been recognized as its own entity. It used to just be a presumed intrauterine insult and provoke seizures. And the neonatal period's really privileged. It's privileged neurologically, medically, and also for health billing purposes. Beyond that, infancy, the first year of life, 1 month up to the first birthday, is also a critical period for development. It's when the seizure incidence in the population is highest. Infantile spasms, Dravet syndrome, and developmentally in children, it's a bit different. So we broke that out. So our primary phenotype is premised on having epilepsy, neonatal onset, infant onset, and then later onset after the first birthday, and then autism. This is really important. I want to point out that all but one of the children with neonatal onset had their first seizure recognized on either, day 1, 2, or 3. It was boom, right there. The one exception was a baby who was born 6 weeks preterm and had the first seizure at day 19. So just basically had to catch up a little bit before having that seizure. What I'd like to summarize for you today is the medical history. We've talked about seizures and syndromes, so I'm not going to talk about that too much, or if at all, but I'd like to tell you about all the other stuff that's going on in your children and how common it is. In terms of pregnancy, labor, and delivery, 79% of you reported that your children were born at term, 17% preterm. That's a little higher than the general population, and most of that was neonatal onset epilepsy, but it's not a huge signal. It's a little bit. Post-term, not really more than I would expect. 41% reported 1 or more complications in pregnancy. That's low. I mean, everyone has a complication of some sort or difficulty. But the one thing that stuck out is a fair amount of oligo or polyhydramnios. And this is a little bit more than I might expect in the population, but I don't know what to do with that. 30% had a complication during labor and delivery. Again, not uncommon to have something happen. But what struck me was the 12% failure to progress and the 12% fetal distress. And I think that's mostly the neonatal onset group. In terms of conditions requiring medical care, including hospitalization in the first month of life, that was 47%. But as you can see, it's mostly in the neonatal onset group. And the most common factors reported were difficulty feeding, jaundice, apnea, and poor responsiveness, largely related to neonatal encephalopathy. In terms of big vital organs, 9% reported any heart condition. What stuck out, though, is that 4 parents wrote in things like irregular rhythm, paroxysmal tachycardia, prolonged QT, and repolarization abnormality due to sodium channel. Those are all pretty unusual. I want to mention it so you're aware of it. In terms of respiratory lung conditions, we did not see a lot of things like asthma, reactive airway disease, but 3 parents reported trachs, and a lot of parents, I don't have the number here, reported things like floppy airways, laryngomalacia, and then also seizure-related breathing disorders or concerns. Dental, dermatology, hearing, everyone in the population has something going on. There was nothing extraordinary reported here, including early tooth or late tooth eruption. There's not a whole lot going on. So just, probably what you're seeing is fairly typical, although we did not go into great details. There might be something specific to SCN2A, but based on these data, we're not seeing big signals. Where we are seeing big signals are vision. 2/3 indicated a vision problem, including 41% with cortical visual impairment. And I want to point out that this depends on the primary phenotype. The neonatal onset group had about 60% reporting CVI, and this dropped with later age at onset and then lowest in the autism-only group. In addition, though, sometimes in combination with CVI, parents reported trouble judging distance, visual motor impairment, impaired depth perception. Those aren't diagnoses, but they're descriptions of difficulties, which may be related to CVI, or they may be something else entirely. And Becky Homer is here, and she might want to comment on that later. In terms of muscle tone, a lot of abnormalities reported, a lot of spasticity, hypotonia, dystonia. These do not have to be separate in a single child, but what you can notice is that almost everyone has hypotonia. The spasticity and the dystonia are most part prominent in those children, again, with neonatal onset seizures. They're there in the others at very high rates, but really prominent in that very young age group. Orthopedic concerns, a lot of scoliosis, and I think you know that. Now, importantly, scoliosis is not something that shows up immediately. It takes time. And if we look at the child's age at the time the parent filled out the questionnaire, we wouldn't expect any in the babies and toddlers, but we start to see it creep in fairly early in the 2 to 4-year-olds, although that child was almost 5. But look in the 10 and older group, 44% reported scoliosis. That's huge. Furthermore, it was particularly predominant in those with neonatal onset epilepsy. And if you put those two factors together, the neonatal onset, who are over 10 years old now, about 60% of them, I think, had scoliosis. So not a lot of numbers there, small numbers, but still something to be to consider. We also saw a lot of parents writing in about hip dysplasia and subluxation. I think that's related to tone. Probably this should go under endocrine, but there's one parent who mentioned osteopenia, and I'm aware anecdotally of 2 other children during the CTRS who have been diagnosed with osteoporosis. In terms of other endocrine issues, 7% of parents reported precocious puberty. This is onset between 5 and 8 in girls and 5 to 9 in boys. This is really rare in the population. That's less than 1 per 1,000, maybe about 0.5 per 1,000. Of course, it does not show up in the first few years of life, but you can see in the 2 to 4-year-olds and now in the 5 to 9-year-olds, we have 14% reporting that. I don't know why we're seeing less in the 10 and older. It may be that parents didn't think about it or forgot about it. I'm not sure. I don't need to tell you that behavior is a huge issue as well. Altogether, 60% of you responded that your children had been diagnosed with autism or had features of autism. We know that. Dysautonomias, nobody talks about it, but this is the nervous system, and the ANS is impacted when there is a central nervous system problem. or peripheral too. We queried 37 symptoms, and only 14% of parents said their children had none of these symptoms. 86% reported symptoms. The median number of symptoms was 6.5. These are grouped into categories for easier reporting. Median number of categories was 4. And the really, really common ones were things like salivation, swallowing, and aspiration, or chewing rather, temperature dysregulation, peripheral blood flow issues, red skin, blue skin, splotchy skin, a lot of constipation and dysmotility. I bet you're not surprised to hear that. A lot of pain hypersensitivity or insensitivity, and also excess irritability. The other thing I want to point out is the urinary retention. We don't think about that so much, but that can be a really serious problem if it backs up into the kidneys. 11% of you reported your children had autonomic storms. It's not super duper common in your community, but they're terrifying. They're very distressing, and they're not well understood. And then lastly, I wanted to mention sleep disturbances. Your kids don't sleep. Almost 50% of you reported that your kids woke up multiple times per week, 3 or more nights per week. And this wasn't necessarily seizure related. This was without, there's some of it seizure related, but it's even without seizures. And then if we add in those who say their children wake up 1 to 2 times a week, we're at about 2/3, these 3 pie pieces. A few said wakes up now and then, some said never, and a few said I don't monitor, I don't know, and that's fair. So just a quick summary of all of this, and that the things that I think are really common and important for you to keep in mind are that tone, dysautonomia, sleep, vision disturbance, and autism are major features, not, I won't say ubiquitous, but extremely common across children with SCN2A related disorders. Also really important, the scoliosis. Particularly in the neonatal onset group, and particularly in anyone with hypotonia. I think that's where a lot of it's coming from. And then finally, the endocrine issues, heart, lungs, not the most common. They certainly, I don't think they'd be something we'd look at in a trial. I wouldn't know what the outcomes would be, but just to have on your radar and to let your physicians know to have that on your radar, that these are things that come up in your children. They can be very serious, and you should just be aware of that. Okay, I'm going to stop now and take a complete left or right or turn, 180 degrees, because as I mentioned, we have this fantastic opportunity to update you about all of this stuff and how it relates to all the amazing work that you heard about channel function the last few days. Based on some brilliant work that was done by people who are here at this meeting, Roy Ben Shalom, Stefan Sander, Kenneth Bender, we started understanding the relationship between the gene mutation, that little change in spelling, how it changed the protein, the SCN2A, the NaV1.2 protein, and how that changed the function of the channel. And based on their work, also some work by Marcus Wolf, Begman, and a few others, but those are the 3 studies I've really focused on. We now have an understanding of gain of function mutations leading to benign familial neonatal infantile epilepsy, or to early onset epilepsy with encephalopathy. And remember, early onset in the literature has been defined as under 3 months. We've changed that in our work a little bit. Later onset, loss of function mutations lead to later onset epilepsy over the age of 3 months, or autism spectrum disorder without epilepsy. And then there's a little bit of a story, 1 or 2 patients reported with mixed variants, mixed function variants, and there's an idea that that might be associated with infantile spasms, but the literature there is not terribly robust, I don't think. So we had this fantastic opportunity to partner with Al George and one of his senior scientists, Chris Thompson. In the CTRS and the global survey combined, 69 unique variants were reported. We have some recurrent variants where multiple families had multiple children had exactly the same variant. Chris took those variants and engineered them into hex cells and studied all of them on the Syncropatch 384, fondly known as DUS machine. And Dennis, Maybe you can talk to Al about misgendering. A lot of work went into that, a huge amount of work, and I'm not the person to discuss that. You heard Dr. George talk about it a bit the other day, and I would do it a great disservice. I'm just going to tell you the current final characterization of the variants. Chris is still doing a little bit more work on curating data. We don't expect many changes to occur. We have a few that on the synchro patch, and based on looking at 10 different biophysical measures, a few come out as gain of function. Some come out as mixed function. We have a group in yellow that come out as wild type, no detectable change from wild type. That doesn't mean they're not pathogenic, but in this model, they do not appear to be. And Kevin can tell you a lot about that. We have the moderate loss of function, where there is still a sodium current going through the channel, a severe loss of function, where there's minimal sodium sodium going through the channel, and then truncation. It's gone, complete loss of function, complete loss of protein product. These vary tremendously across our primary phenotype as we've defined it. Very much as you would expect from the earlier work, all of the gain of function are showing up in the neonatal onset, not the early onset. These are the kids with seizures on day 1, 2, or 3. Our mixed function variants are also showing up there. The wild type variants are showing up there, but we also have a couple loss of functions showing up in our neonatal group. As we move to the infant onset, 1 month up to 11, up to the first birthday, we see a lot of mild, moderate loss of function, some of the severe, and I think one child with truncating. We go to the later onset, we have these 2 yahoos out here who just, we don't know what the mixed and wild type, what we have exactly. They showed up here, but we see less mild loss of function and a lot more severe and truncating. And then finally, when we get to the autism only, 1 mild but moderate, and then very severe. And over half of these children had truncating mutations. And I think this is really consistent with what we've seen from the work of others, and it's kind of building on it by pulling out the neonates. I've talked a lot to this group about functional abilities, not in the variants, but in your children. And now I'd like to bring this all together. We've talked about the impairment in gross motor skills, that many children can't walk, they're in a wheelchair, do not have purposeful hand grasp to pick things up, are entirely dependent on a G-tube for nutrition, and are unable to communicate effectively, even with people very close to them, their parents and close caregivers. Based on this, and also a few other things, I began to become aware of the scoliosis and CVI. We've created a very simple non-seizure severity index. And the index is simply a sum of how many of these a child had. So if a child had none of these, the score was 0. If the child had all of these, the score was 6, and then anywhere in between. Okay? That non-seizure severity index tracks really nicely with the primary phenotype. The darker the colors, the more severe, that's how it's done. And you can see that the neonates have the most severe spectrum of presentation. It lightens up a little bit with the infants. It lightens up a lot more with the later onset. And when we get to the ASD, autism or ID only group, that's where we see the least impairment. Now, I do want to point out the children with 0 of those, they're still very impaired. This is not benign neonatal or familial epilepsy. They are still quite impaired, but they have some function. So I've told you that primary phenotype is strongly correlated with channel function. It's strongly correlated with severity index. And you're probably wondering, well, does channel function drive severity index? Good question. The answer is yes and no. It's a little complicated. We'd sort of expect if that were the case, we'd see a nice continuum of change across the board here with again, the severity index being represented by the darkness of the color, but it's not quite that simple. So in an effort to figure this out, we resorted to some exploratory techniques called cluster analysis. And I won't go into what that does, but it basically just tries to group people based on several different factors into the most similar. Into similar groups. So we've got 3 factors: primary phenotype, severity index, and gain of function. The question is, how can we group these into groups where the groups are as different as possible and within the groups they're as similar as possible? And the answer is, the first thing you do is you put the neonatal onset into one category over there. They're there. And then we put everyone else over here. Beyond that, within the neonatal onset group, the loss of function children stood out. They had the most severe presentations. Their index was 5 or 6. They either had all five or all 6 of the factors that I mentioned. The other group was all of the gain, mixed, function, and wild type like. Their severity was mild to moderate. There was 1 or 2 in the 6 category, but the median number of severity factors was 2.5, much more moderate as a group. The next group was all of the infant onset. There were 4 from the later onset group, but 3 of them actually had their first seizure right after their first birthday. So, it's a problem with making cut points. I'll have to check their gestational age. These children had the moderate loss of function, and a few had severe loss of function, and their overall severity index was broad, 0 to 5, but like the neonates, the median was 2.5. So it's a mixed group in terms of severity, but trending towards the more moderate side. And then the last group, of course, was all of the autism, almost all of the later onset. This was where we saw the severe loss of function and most of the truncating variants in this group. Their severity index was the lowest, 0 to 3, with a median of 1. And when it was a 1, it was almost always communication. So I think I got it all in pretty much. So just real quickly, thanks for letting me talk fast. A couple take-home points from this last piece. I think we need to be much more specific, pull out the neonatal onset from the infant, from the older onset. It's really important, developmentally, neurologically, in every possible way. And the realize that those non-seizure phenotypes are much more severe with earlier onset epilepsy, and then at least in the ASD group. After 30 years of looking at outcomes in children with epilepsy, this is exactly what I would expect. So it's not a pattern that's really different from any other form of epilepsy that I've looked at. The channel function to phenotype piece, I think we've really getting that locked in, the basics from the literature, from your work. We've got it. The severity of loss of function is strongly correlated with primary phenotype. The non-seizure phenotypes, that's a little bit more complicated, although in general, as I said, the earlier the onset, the more severe. But there is that cluster of neonates with loss of function severity. And we had this fantastic discussion at dinner last night, and we continued it this morning about how do we know what model is really giving us the best understanding of gain versus loss of function? It's a philosophical question that has to become operationalized eventually. Very quickly, and not in enough, I don't have enough time to do this, but this study would never have been possible without all of you, the parents from the family's SCN2A group. Thank you. I was fortunate to have an extraordinary team at Northwestern, the CTRS team, the CWOW team, Chris Thompson and Al George, and none of this would have been possible without the family's SCN2A mutation foundation. Leah, Carla, Jenny, Michelle, and so many others who have come on board since then. So thank you.